Hello and welcome to part 1 of 2 on parasitic infections, specifically focusing on the endoparasitic group of helminths, or parasitic worms, where we will discuss some of the basic biology required for clinical practice, the most important parasitic worm infections relevant for a clinician in North America, as well as an in-depth look at the clinical pharmacology for antiparasitic agents. I'm Jackson Stewart, and this lesson is focused more for those practicing in infectious diseases or who are very interested, since this topic is quite uncommon. We will learn how to approach the topic and choice of pharmacotherapy as thoughtfully as we can. I think the most important goal is to try to take all of the clinically relevant helminths and create a mental schema so that we can recall them when needed in clinical practice using a focused memorization strategy. We should be able to list all the clinically important helminths by biological order, but also by recognizing specific helminths by their clinical milieu, i.e. how they are transmitted or acquired and where on earth they might cause problems. Second, we'll cover each of these infections, focusing on high yield distinguishing features of each, and then we'll do a bit of a deep dive on what literature exists regarding the clinical pharmacology for anti-Helminthic agents. We'll do some quick clinical cases and review questions, and then round off the discussion by talking briefly about how Helminthic infections are managed more frequently in veterinary medicine. To begin, let's briefly refresh what we're referring to when we talk about parasitic helminths. The term helminth, of course, being from Greek origin, referring literally to an intestinal worm, something that humans have noticed since ancient times as a clinical problem in medicine. Helminths of any sort refer to a flat or round, generally elongated invertebrate, but some may indeed be quite small and difficult to see. The term platyhelminth refers literally to a flat worm, which includes two of the three clinically important helminths, the Cestodes or tapeworms, and Trematodes or Flukes. Nematodes referring to the third group, the most abundant in clinical parasitology, the roundworms, nemato having a Greek root in thread. Remember to contextualize when learning any infectious organism in the grander scheme of pathogens, parasites being one of the four major groups of infectious organisms, which can itself be broken down into the two groups of endoparasites, either the protists, often unicellular, or the helminths, multicellular worms, which we'll focus on today, but as well as the ectoparasites, generally arthropods or other bugs. We divide up helminths into three groups as previously stated, the nematodes, the cestodes, and the trematodes. Nematodes, of course, being non-segmented cylindrical shaped worms which contain an alimentary tract with several important members, for example, being the intestinal ascarids and strongyloides, which is of great clinical importance. Cestodes are segmented flatworms, colloquially referred to as tapeworms, which lack a digestive tract and absorb instead longitudinally. Tapeworms can reach up to 40 meters in length. The clinically important tapeworms are much fewer than nematodes and can be easily divided up by how they're acquired. The last small group is the trematodes or flukes, which are much smaller worms, capping out at about 7 centimeters at the very largest, which typically have a tropism to a specific organ system in the host. In the flukes we'll discuss today, that looks like the liver, the lungs, or the GI or GU tract. Understanding the broad strokes of the biological life cycle of these organisms extends into nuance, but remains clinically relevant since understanding from a public health perspective how to reduce public infection relies on our understanding of where and how these infections continue to propagate. We'll briefly touch on this, although today we'll narrow our focus more on recognizing a patient who needs consideration for worm infection, diagnostic strategies, and treatment. Nematodes, as mentioned, are cylindrical with a full alimentary canal, including some form of sensory papillae on the mouth, sometimes with attachment features like those seen in hookworms. Eggs created are deposited into the feces or into host tissues that produce larvae, and larvae generally have multiple stages, but in general culminate in adulthood. Worms may be detectable clinically in larval or adult stages depending on the site of deposition or migration. Tapeworms, or cestodes, as previously mentioned, are flat segmented worms with individual segments called proglottids. Some tapeworms have up to several thousand segments. Anatomically, every tapeworm has a head or a scolex, which bears a couple of fang-like organs of attachment, a neck, and a chain of proglottids, which is called the strobila. Neck proglottids are generated from the neck region, so segments close to the neck are the youngest, and the terminal proglottids are gravid and have egg-filled uteruses. Tapeworms have no alimentary tract, instead are absorbing nutrients lengthwise through the strobila, and the tapeworm in general is different, that the excreted element may be an egg or a cyst, which is not the same thing. If cysts are ingested, which is the most common, rolled up in dormant proglottids, they continue maturation into an adult worm which excretes eggs into the feces. If the eggs, however, are ingested, larval worms will then form. Cysts which cause a different problem, for example, cysticercosis, which is unique to tapeworm infections, as we'll discuss. Lastly, trematodes or flukes are leaf-shaped flatworms that can range from a few millimeters up to 7 centimeters in length. Most are hermaphroditic, so they have both male and female reproductive organs. A generalized life cycle involves eggs, which are passed in the urine or feces and reach an aquatic environment. The eggs then hatch, which then can enter a snail intermediate host, very commonly for several of the flukes, either by the snail eating these eggs or the eggs hatching into larvae and then penetrating the snail host. At the cercarial stage, as larvae and cercaria from the snail are able to swim and either penetrate directly into the skin of a human or penetrate into another intermediate host like a fish, where they develop as an encysted cercaria and then are eaten by a human, which liberates an immature fluke and develops to adulthood in the specific tropism organ. Importantly, detecting helminths in clinical practice is difficult, and outside of keen clinical attention to details in a history, we have few microbiologic techniques that are useful for identification, particularly because helminthic infections are quite rare in most practices in North America. Our options are limited. In general, you can think of 3 separate options that we have for recognition of a parasitic worm. First, the identification of a whole worm or ova or eggs or cysts in the stool, which of course would only apply to worms which have made residence and shed stages into the feces. Some worms, like those transmitted by biting flies, for example, have no GI stages. Second, we have serology or IgG testing, which is useful for some worms that are difficult to find in the stool O&P, but only tell us someone has historically been exposed, which may be enough justification in some cases for empiric treatment, but only generally becomes positive in infections which are angio or tissue invasive. For example, we wouldn't expect seroconversion for Enterobius vermicularis or the pinworm infection. And thirdly, tissue or specimen biopsy, for example, a peripheral blood smear or direct sample from an infected organ, is less practical, more invasive in general, but may be necessary and tricky to identify infections, i.e. the nematode Anisakis simplex, which might be identified on upper endoscopy. Ultimately, these tools are most useful when approached thoughtfully with pretest probability given the clinical milieu. The stool ova parasite, or ONP, is the most commonly used technique to look for helminths and GI protozoa, which involves the collection of a stool sample with smear and microscopy, observing for frank worms, ova, or cysts if visible. As you can imagine, the sensitivity is increased by multiple specimens, so if you have good reason to suspect a helminthic infection, multiple stool samples are justified. A study from Canada in 2012 out of London, Ontario, retrospectively surveyed the use of stool ONP for parasitic infections, finding unsurprisingly that it has low diagnostic yield. This is probably in part due to, first, that these infections are rare in the first place, but also second, that there may be a practice of sending unnecessary stool ONPs as routine surveillance in patients who may have non-specific GI complaints. Suffice to say, we can probably be better laboratory stewards by being thoughtful prior to ordering a stool ONP to go fishing for hopefully finding an organism. In this lesson, we'll practice thinking deliberately, which exact worms am I suspicious for? If you can name them and justify them, we can probably order these tests more intelligently and increase our yield. So now let's get into the clinically important helminthic infections that we need to know. We'll start with nematodes, then progress to our flatworms. The nematode group is the largest and hardest to remember, with the most individual members causing clinical disease. For this reason, I've broken them into 4 subgroups that we can mentally go to every time we consider roundworm infection. First, the ubiquitous and well-known pinworm infection, something every clinician should know of by now. Second, what can be called the poor sanitation tetrad, a group of roundworm infections that only occur where people are either stepping in or eating food contaminated with human feces, which include our ascariasis, trichuriasis, as well as our hookworm infections and strongyloidiasis. Our third group can be referred to as our animal exposure or food contamination, splitting between those acquired from animals like toxocariasis and Balis ascariasis, and those acquired from contaminated food like trichinosis and angiostrongylliasis. Lastly, our fourth group, the vector-borne nematode infections, either acquired through mosquitoes, i.e. Wuchereria bancrofti and Brugia millei, causing lymphatic filariasis, or through biting flies, i.e. Onchocerca volvulus or Loa loa, which are endemic to certain tropical regions. With that, we have memorized the broad groups for the most difficult group of helminths. Spend time reviewing the schema to secure it in your long-term memory for recall. Let's start with pinworms, the most common helminthic infection worldwide, caused by the roundworm Enterobius vermicularis, sometimes called threadworms in some resources. Pinworms are really an ancient human infection, with fossilized Enterobius being identified in coprolite, or fossilized human poop, so we are quite familiar as a race with this organism. Pinworms occur anywhere on the planet that there are people, often persisting and reoccurring in family clusters with fomite spread and close contact. Most commonly, children are infected through fecal soil oral transmission. Children and adult hands may be contaminated with the eggs deposited in the soil with feces, especially under the fingernails, and ingested. Enterobius is suspected to be quite hardy, surviving for weeks or months on fomites like bed sheets or household items, making it easy to pick up in family clusters. The eggs ingested hatch in the GI tract, where larvae grow into adulthood. At night, for some reason, gravid females migrate to the anus and deposit eggs on the perianal skin, which can be shed in the feces for self-limiting infections as the adults die of old age with good hand hygiene. Unfortunately, if hand hygiene is not maintained, autoinfection can occur with scratching of the perianal skin and possibly infections of others in this way as well. Humans are the only definitive hosts, but you can imagine how household pets could become vectors if contaminated via their fur. This emphasizes the role that hygiene and household sterilization has on the successful treatment of recurrent pinworms. Most patients infected are asymptomatic, but with heavy worm burden, intense perianal itching, especially at nighttime, is the chief symptom, with this manifesting even as nightmares or strange problems like nocturia in pediatrics. Rarely, secondary bacterial infection from excoriation might occur, and if migratory to the vagina, vaginal discharge in pediatrics has been reported. Interestingly, pinworms are not infrequently found in the appendix post-appendectomy. Whether or not they have a causal role in appendicitis, however, is unclear. The diagnosis of pinworm infection really is clinical. The classic history should prompt for consideration of empiric treatment, but strategies involving obtaining a Scotch tape sample of the perianal skin first thing in the morning in office, or if the patients are up to it in the middle of the night, or through fingernail scrapings, may identify ova through microscopy. If a patient notices small thread-like white worms, this is probably enough for diagnosis. Treatment includes a simple regimen of pyrantyl pamoate, which is available over the counter, typically given to all family members to improve efficacy. But as previously stated, a hygiene/fomite cleansing change that reduces reinfection rates, i.e. stop thumb sucking, trimming fingernails, cleaning bed sheets and clothes in hot water, might be required to reduce reinfection. Now that we've covered pinworms, let's get into the first large group of nematode infections, the poor sanitation tetrad, a group of roundworm infections easily grouped together that can actually concurrently infect a single patient, given the shared risk factor of poor sewage and lack of indoor plumbing, leading to human feces being present in the soil around human settlements, where it is either contaminating the hands and food of patients or being stepped in patients with lack of good protective footwear. If that risk factor is not controlled, these infections will continue to circulate in these patients' populations, and although patients may not remember specifically eating or being contaminated with human feces, it's reasonable to check for these helminths in patients from areas where this is a possibility. These are divided into the poor sanitation fecal oral group, ascariasis, and the whipworm infection, trichuriasis, And the worms that penetrate the feces directly into the feet or skin, the hookworms, Necator americanus and Ancylostoma duodenale, and the very important Strongyloidiasis. Ascariasis is the second most common helminthic infection worldwide. It's suspected in some texts that 25% of all humans on Earth are or have been infected with this worm, sometimes called the pig roundworm, since a similar infection affects swine, a roundworm called Ascaris lumbricoides. As previously stated, humans, the definitive host, acquire it from human fecal contaminated soil, where it is ingested as eggs, hatches in the GI tract, and then burrows into the GI tract wall. Interestingly, as we'll see with a few other of these poor sanitation worms, it has a roundabout way of maturing and reaching adulthood, which it does by burrowing into the GI tract wall, traveling into the bloodstream and heart, and then getting pumped into the lungs, where it will grow and then is spit up and swallowed back into the GI tract. This lung portion of the life cycle is really important to remember since it causes some problems. We don't know exactly why some worms do this, but not others. It is suspected that increased oxygen availability is important to growth in some larval stages for some worms. Either way, the worm lays eggs, which are shed in the feces, and the cycle begins again. If patients were to lose the risk factor, their infections would generally be self-limiting with passage of dead adult worms. As you can imagine, many patients are asymptomatically, unknowingly having this worm in the GI tract, but very few develop an acute pneumonia related to that lung stage of their life cycle known as eosinophilic pneumonitis or Loeffler syndrome, which we'll discuss. This syndrome can occur with any worm that has a lung stage. More commonly, chronically, some patients will notice that they spontaneously pass worms in the stool. Rarely, some have nausea or abdominal pain or malabsorption, like a steatorrhea, with most harmfully developing intestinal obstruction in heavy burden cases. In these heavy burden cases, obstruction and migration may increase the risk of gram-negative bacteremia and sepsis from bacterial penetration. Thus, treatment is justified if active infection is suspected. Luckily, our stool O&P should be a great technique for spotting Ascaris since it has a large egg with a rough coat. Sometimes the worm can be directly spotted with a visual diagnosis in stool samples or even through colonoscopy. Treatment involves mebendazole administration, but remember to break the life cycle. We need to remove the risk factor of poor sanitation. We will mostly see this infection in North America in recent immigrants from high-risk developing countries. I mentioned this acute pneumonitis picture that occurs with ascariasis due to the lung stage of development. This was first formally recognized by the Swiss physician Dr. Wilhelm Loeffler in the early 1990s, which noticed a tropical pulmonary eosinophilia syndrome which mimicked a bronchopneumonia or lobar classically community-acquired pneumonia, with the distinction of lack of improvement on antibiotics and peripheral or sputum eosinophilia. Interestingly, the chest X-ray findings may be migratory and transient, possibly due to migration of worms and mucus plugging as a result. This is probably an immune reaction more than it is an infection of the lung. In many cases, no cause is identified, but the term Loeffler syndrome probably refers more specifically to a Helminthic-induced eosinophilic pneumonia picture. Most cases are self-limiting as the worms exit the lung. Some case reports have even identified patients resolving spontaneously, correlating with an episode of coughing up frankworms in their sputum. The other infection caused by the same problem of fecal soil oral contamination with human feces is the whipworm infection caused by the whipworm Trichuris trichiura, a worm with a characteristic shape seen on the left and a football-shaped ova with light bulb attachment ends on microscopy. The distinction between this worm and Ascaris is that it does not involve a lung stage in its life cycle, instead burrowing into the GI wall and living there sometimes for up to 3 years, causing some chronic problems. Most patients are asymptomatically infected, although less commonly, whipworms are a known cause of worm anemia, literally sucking blood from the GI tract wall, although in very small quantities per day. Over years, this can look like an iron deficiency anemia over time. In rare cases with heavy worm burden, the whipworm causes more of an intense GI syndrome, dysentery syndrome, although not truly dysentery, with bloody diarrhea, and even possible frank rectal prolapse from chronic tenesmus and squatting to defecate. Stool ova parasite is effective in identifying these characteristic eggs. Patients may develop a peripheral eosinophilia, and treatment involves mebendazole very similarly to ascariasis. Again, don't skip the negation of important risk factors. Now moving on to our poor sanitation roundworms that burrow directly through the skin. First we have our hookworms, both Necator americanus and Ancylostoma duodenale being common hookworms that cause a cutaneous larva migrans and GI syndrome. This is because the worms burrow through the feet in contaminated fecal soil and migrate to the lungs through the skin before being coughed up and swallowed into the GI tract, where they make residence, burrow, suck blood, and lay eggs. You can imagine, therefore, that Loeffler syndrome is possible with these worms. The worm can live for up to 5 years, but only recurs if the risk factor persists. Many patients are asymptomatic, but some patients have noticed cutaneous larva migrans, a serpiginous rash that looks like a worm that's burrowed through the skin, but actually is a rash reflecting where their worm used to be, and is actually a subsequent IgE-mediated reaction. Pruritus can lead to excoriation and secondary infection, and Loeffler syndrome, as I said, is possible. After the worm takes GI residence, like in whipworm infection, it can cause hookworm anemia, an iron deficiency anemia over years due to slow blood loss, and rarely growth restriction in children. Therefore, it's an important concern in these countries. Rarely, patients will notice past worms in the stool, but hookworms and eggs can be found easily in the stool ova and parasite. But we should always ask about cutaneous larva migrans, patients might remember. Treatment involves giving mebendazole or ivermectin. Some data suggests that albendazole is more effective, but it's harder to acquire in North America. These agents should be tried first. You can give antihistamines for the itch and consider managing that iron deficiency anemia if patients have it. Lastly, for our tetrad, we have the important strongyloidiasis caused by the same problem as hookworms, but with a very problematic lifelong infection due to the unique life cycle of Strongyloides stercoralis, the causative roundworm. Strongyloides enters through the skin, penetrates the vessels, heart, and lungs. Yes, it can cause Loeffler syndrome as well, just like hookworms. But when Strongyloides enters the GI tract, it matures, lays eggs, and does not need to leave the human host to complete its life cycle. Some eggs will be deposited into excreted feces like with other worms, but some can actually be deposited into the rectum itself, or the perianal rectum, and hatch before reburrowing into the GI tract and restarting the life cycle. This means that autoinfection and lifelong chronic infection is possible even if the patient has lost their risk factor, for example, immigrated to Canada or the US. This makes strongyloides the more likely of the previous roundworms to become a problem, particularly if you're seeing patients in North America. Just like hookworms, the burrowing through the skin can cause a cutaneous larva migrans rash we call larva currens, which might be more brief and rarely causes Loeffler syndrome. Strongyloides, however, does not cause some of the chronic GI problems that we see with hookworms or whipworms. Instead, it mostly lies dormant, causing no problems for the lifespan of the human. However, the most important clinical scenario is a life-threatening, overwhelming hyperinfection in patients who become immunocompromised, which can lead to hyperproliferation and reproduction of the worms and overwhelming gram-negative sepsis, including lung infiltrates and ARDS. This is of the most concern when patients are undergoing chemotherapy or organ transplant, so strongyloides must be tested for in at-risk individuals prior to immunosuppression. We do this most commonly via a reliable serology, since although a stool ONP may be useful, we expect positive serology due to angioinvasion. The treatment is simple, with ivermectin being preferred over our benzodiazoles as a single-dose cure. You may even consider giving the dose empirically in the absence of positive testing due to the ease of treatment if the pretest probability is high enough by risk factors. Importantly, if patients develop hyperinfection syndrome, mortality is high, and patients should be treated with broad-spectrum antibiotics as well as ivermectin. Some authors state to use albendazole in addition, although this may be due to futility of expected outcome. Now let's move on to our third group of nematodes, the roundworms acquired through animal exposure or eating uncooked food. Acquiring helminths via eating undercooked food is more characteristic of tapeworm infections, as we'll see, but a few nematodes can cause problematic disease with this as well. For animal exposure, we have worms associated with each of dogs, cats, and raccoons, namely Toxocara canis or cat eye for dogs and cats, and Balis ascaris procyonis for raccoons, all of which can rarely happen in North America. And for undercooked food, we have hunted meats with Trichinella spiralis and undercooked seafood disease caused by either Anisakis simplex or Angiostrongylus. This entire group of nematodes cause interesting clinical syndromes, mostly as a result of the fact that worms found in the muscles of animals that are eaten may want to migrate to your muscles to try to get eating themselves, and humans are accidental hosts, causing strange problems as these worms migrate aimlessly. We'll talk about Toxocara canis and cat eye and Trichinella together, because although they are from different routes, they behave similarly in terms of their tendency to migrate within human hosts, ending up in problematic places. Toxocara canis from dogs or cat eye from cats are roundworms that cause separate veterinary infection of outdoor dogs and cats in North America and worldwide when they eat contaminated soil with feces, hence not a significant problem for indoor pets. Either way, humans become infected when ingesting food. Contaminated hands become contaminated with dog or cat fecal soil as we get a GI tract worm that migrates trying to find dog or cat organs and instead ends up in strange places and dies eventually. This migration is called visceral larva migrans, since it ends up in organs rather than the skin, possibly causing protean or non-specific symptoms like fever, lymphadenopathy, and hepatosplenomegaly, but can rarely cause ocular larva migrans, a visible worm in the eye, or even traction retinitis, looking like a loss of the red reflex like a retinoblastoma, or even Loeffler syndrome, or even a meningoencephalitis. Diagnosis is tricky since it doesn't necessarily shed much into the GI tract while it migrates, so serology testing is reasonable. Treatment may not be necessary since worms die on their own, but if patients are clinically ill, corticosteroids may reduce inflammation before giving something like albendazole or mebendazole, which cannot kill muscle migrants but may limit further disease. Deworming our dogs and cats routinely is our best protection for outdoor companion animals. For trichinosis, caused by Trichinella spiralis, with its characteristic spiral phenotype, is caused by ingestion of undercooked hunted meats, which contain dormant roundworm cysts, namely in bears, walrus, or cougar jerky most frequently. So it's commonly known to be a disease of hunters. Ingestion of this meat leads to GI tract infection with Trichinella, which then migrates to try to get into our muscles, but ends up, just like in Toxocara, going to strange places as a dead end. Importantly, Trichinella tends to cause more muscular problems, as you can imagine, causing prolonged muscle pain, pain around the eyes, and periorbital edema, even with some problems like myocarditis and, again, meningoencephalitis with resulting coma. Diagnosis again would be through serology, and treatment involves steroids if needed, plus minus albendazole or mebendazole. The best way to deal with Trichinella is to avoid eating undercooked meats, particularly from these hunted animals. Those are the nematodes acquired from dogs and cats. We can also be infected by a roundworm due to proximity and relationship with raccoons, in particular from eating food contaminated with fecal matter of raccoons and containing the infectious eggs in the soil, rarely via other means of very close contact with raccoons, and companion raccoons are becoming more popular, but specifically hunters, trappers, or taxidermists would be at high risk. This occurs anywhere in the world where raccoons are infected and humans have close proximity, so this is possible but rare in Canada and the United States. Raccoons are the definitive host of Balis ascaris procyonis, and humans would be a dead-end accidental host in this case, where the eggs hatch in our GI tract, penetrate the GI tract wall, just like in Toxocaris infections. Balis ascaris migrates and causes a visceral larva migrans, but importantly is known to characteristically cause a neural or CNS larva migrans, causing an acute eosinophilic meningitis presentation with seizure, ataxia, or coma possible. But also, just like toxocaris, causing ocular larva migrans as well, with possible retinitis and blindness. Diagnosis, because of angioinvasion, can be done successfully with serology, although there may be delayed testing. A stool ONP could be attempted, and an MR brain should be obtained if neural larva migrans is suspected. While reading on Baileys ascariasis, the impression is that treatment attempts are considered with some degree of futility. Patients end up either doing very poorly or recover spontaneously due to humans being a dead-end host. Attempts at treatments involve corticosteroids for inflammation, and albendazole is the most studied comparatively to mebendazole or ivermectin, but there seems to be overall skepticism regarding its effect, maybe given more for the sake of offering some form of treatment. We can also obtain some nematodes from eating undercooked seafood or snails. Anisakis simplex is a roundworm that is obtained via ingestion of undercooked fish or squid, where they are infected by free-swimming larvae. The larvae burrow into our stomach, but we are luckily dead-end hosts. Not all seafood is likely infected. Undercooked fish and squid must be previously infected, which is probably more of an endemic problem around Southeast Asia, predominantly in Japan and Korea. Anisakis does not migrate like some of the other nematodes we've mentioned, but characteristically causes an abrupt, severe abdominal pain hours after eating the larvae, which you can see could be easily confused for bacterial food poisoning. The stomach and duodenum is characteristically infected, hence causing this presentation, with a possible subacute presentation 1 to 2 weeks later with an inflammatory diarrhea picture resembling Crohn's disease. It would be expected this would resolve spontaneously as we are dead-end hosts, usually in weeks. If diagnosis is pursued, serology might be possible depending on where you work, not in Alberta, and Anisakis worms can possibly be even seen in upper endoscopy, since they live in the stomach and upper small intestine. Treatment also has an air of skepticism, given lack of substantial benefit of benzodiazoles. Upper endoscopy may be able to remove a significant burden of the worms. Freezing undercooked fish may help reduce worm burden if it cannot be cooked via cultural or dietary preferences. Our last roundworm via this route is Angiostrongylus catanensis, also known as the rat lungworm, since it is usually passed back and forth between rats and snails or slugs. Humans would be accidental hosts if they eat undercooked snails or slugs, or eat produce that is contaminated by their slime. Rarely eating intermediate hosts, i.e. fish, shrimp, or frogs which eat the snails could theoretically cause this disease. This again is mostly a problem with infected populations, commonly in Southeast Asia and the Pacific Islands, which bears an abundant snail population. Importantly, however, Angiostrongylus is also a migratory worm, finding its way to the brain and eyes in a dead-end host, fashion similar to Baileys ascaris and toxocariasis, causing an acute eosinophilic meningitis syndrome. Think of this problem in travelers to Southeast Asia who have eaten snails or slugs and developed neural larva migrans. Serology is not commercially available, so diagnosis is difficult. If tissue is available or can be smeared, potential visual or pathologic diagnosis may occur. Caution is placed for treatment, since there is a concern with treatment and killing of CNS worms and the pro-inflammatory effect that it might have. A small number of studies have demonstrated nil benefit of any anti-helminthics, so in general, therapeutic LP taps and corticosteroids are indicated alone. To finish our largest group, the roundworms, we have the vector-borne nematodes, those which are carried and transmitted to humans either through the bite of a mosquito, in the case of lymphatic filariasis caused by either Wuchereria bancrofti or Brugia malayi, or through the bite of a particular biting species of fly, either involving Onchocerca volvulus or Loa loa. Importantly, all of these infections are tricky to manage, but typically only occur endemically in sites with populations of infected vector species, so it is uncommonly encountered. An important nematode infection carried by mosquitoes in the tropics is lymphatic filariasis, sometimes known colloquially as elephantiasis, which is caused by one of the filarial nematodes, a specialized group of nematodes called filaria, which always have an arthropod vector. Two important filaria are Wuchereria bancrofti and Brugia malayi, although there are others. Very interestingly, these parasites have evolved within mosquitoes and humans to develop an endosymbiotic relationship with a very interesting alpha proteobacteria called Wolbachia in the Ehrlichia family of Rickettsialis, which seems to be infecting these worms, but in fact provides some mutualistic benefit. Without Wolbachia, these worms cannot survive, which leads the treatment of lymphatic filariasis to depend on doxycycline treatment. After being bitten by a mosquito, the worm travels through our lymphatics, where it likes to grow and feed off of lymph, unfortunately causing clogging of lymph vessels and chronic lymphedema, often in the extremities, but also in the breasts and genitalia most commonly. Patients with lymphedema can get secondary infections related to complications in skin care. Less commonly, with high worm burden, microfilariae that travel into the blood intermittently can get into the lungs and actually cause a Loeffler syndrome as well. Diagnosis is clinical, combined with serology and ultrasound. Treatment as previous, relying on doxycycline killing of those symbiotic Wolbachia species, while potentially using anti-Helminthics like albendazole or diethylcarbamazine to reduce parasite load. Unfortunately, once lymphedema has occurred, it is difficult to reverse it surgically. Our last group include Onchocerca volvulus, carried by black flies in tropical rainforest belt areas near rivers, and Loa loa, carried by tabinid or horse or deer flies in sub-Saharan Africa or even South America in the Amazon. In both cases, being bit by one of these flies causes a local skin infection, which causes subcutaneous tissue migration and development of hard nodules, with subsequent skin migration causing a diffuse IgE-mediated skin reaction and eventual involvement of the eyes in some way in both cases. In onchocerciasis or river blindness, in addition to these patchy nodular skin changes, patients can develop a problematic sclerosing keratitis and lens subluxation, which can lead to blindness. In loiasis, patients may have ocular larva migraines, but actual damage to the eye is quite rare. Instead, patients can get features like calabar swellings, which are like local IgE-mediated welt regions, or rare delayed hypersensitivities like immune complex glomerulonephritis. Diagnosis in each case involves serology, skin biopsy of those nodules, as well as visualization of eye changes characteristic for these worms. Treatment for river blindness is ivermectin, usually with repeat dosing required, but treatment for Loa loa as a filarial parasite relies on diethylcarbamazine. Importantly, if patients with onchocerca are given diethylcarbamazine or DEC, they can have a reaction to dying worms called the Mazzotti reaction, which can threaten the eyesight of the patient due to dying worms. Patients who are being treated for Loa loa, therefore, should be excluded for onchocerca volvulus prior to starting DEC. And that does it for the largest group of helminths we have to know. Take time to revisit the nematode section for the overall schema to be able to recall these worms in practice. The next two groups are much smaller. The first of the flatworm groups being cestodes or tapeworms, which can be divided easily based on the exposure, either through undercooked food or through infected dog exposure. Patients may have a tapeworm from undercooked fish, beef, or pork with different pathogens, or through close contact with an infected dog in the case of echinococcosis. Starting with the tapeworms you can get from undercooked food, Diphyllobothrium latum is known as the fish tapeworm, classically acquired from eating undercooked freshwater fish, particularly with an increased risk at sites where freshwater is contaminated by sewage drainage. This is uncommon in North America, but may be common in other countries depending on the context. Regardless, ingestion of the fish cysts causes hatching in the GI tract to an immature worm, which attaches to our GI tracts and elongates its strobila. It desires to be pooped out so it can return to the water to complete its life cycle and has reservoirs in other wild animals as well. Most commonly, patients are unaware that they even have the tapeworm, but may notice a passage of a proglotid or whole strobila, less commonly with nausea or anorexia. Rarely, this worm can cause vitamin B12 deficiency as opposed to that iron deficiency anemia we saw with hookworms and whipworms, as well as an intestinal or biliary obstruction. Importantly, tapeworms do not help patients lose weight, and in fact, steal so very little of our nutrients from our food that we hardly even notice their presence. Diagnosis is confirmed easily via stool O&P or proglotid passage, and treatment is simple with a single dose of praziquantel, our usual choice for most flatworm infections. Importantly, freezing our fish may prevent this problem, even if preferring to eat uncooked, as we have seen with Anti-Helminths. In any country where poor meat inspection is taking place or where there is poor sanitation or hand washing post-defecation, you can get infection from eating undercooked beef with Taenia saginata or undercooked pork with Taenia solium, both more common tapeworms in North America. In both of these meats, they may contain cysts as a result of soil or fecal contamination from beef and pork life cycles. Cysts in humans hatch, and then the scolex attaches to our GI tract, causing a taniasis, really just being infected with a tapeworm in similar way to Diphyllobothrium. These worms can live up to 25 years and often live causing no symptoms in humans, sometimes being passed in the stool. Stool ova parasites can easily detect these, and praziquantel can effectively treat and deworm us. The more difficult problem is when humans reinfect ourselves by getting auto or cross-infected with our own feces when we pass eggs and not the cysts into our feces and then re-ingest it. When you ingest a cyst, you get a worm. But if you ingest the eggs, you get the cysts, and cysts want to migrate to your muscles so that they can be eaten by another animal. These cysts are what can cause serious problems and can be prevented, therefore, with good human hygiene practices. Cysts can cause muscle tenderness, like in trichinosis, but can also cause a well-known CNS syndrome called neurocysticercosis, where the brain becomes encysted with multiple Taenia worms. These cysts mostly cause a mass effect, so can result in new onset seizures as a classic presentation in an adult patient. If the cysts are deposited in the eyeballs, blindness can occur, and diagnosis of cysticercosis is trickier, but stool ova parasites plus minus an MRI of the brain can reveal the diagnosis. Treatment is much more difficult, unfortunately. Cysts are generally less responsive to anti-Helminthic drugs, and a combination of steroids and then drugs like praziquantel plus minus albendazole have been attempted in combination with anti-epileptic drugs. Lastly, for our tapeworms, we have a common problem of hydatid cyst disease with echinococcosis, or caused by a tapeworm called Echinococcus granulosus or multilocularis, also known as the dog tapeworm, since dogs are the definitive hosts with both of those species, commonly sheepdogs or domestic dogs with granulosis, or foxes or other wild dogs with multilocularis. Dogs who eat the entrails of hoofed animals like sheep, cattle, moose, or elk can be infected with Echinococcus granulosis, which causes a tapeworm disease in the dog. As you can imagine, if the dog then defecates and humans eat their contaminated dog feces, which contain eggs, we can ingest the eggs, which will cause a cysticercosis in humans. This occurs worldwide, where humans have intimate contact with dogs, which are allowed to feed on these hoofed animals. Humans often do not develop symptoms of echinococcosis for many years, but eventually develop a mass effect problem from cystic lesions, most commonly in the liver, as seen on the MRI to the right, which can present as a right upper quadrant pain and jaundice, but also possibly in the central nervous system as well as seizures, similar to neurocysticercosis. Importantly, these cysts contain highly antigenic fluid containing proglotid segments that, if you puncture or rupture these cysts, can lead to an anaphylaxis due to a host immune response. Diagnosis involves serology, which is easily available, and imaging for cysts, although treatment is very tricky. Several surgical options are available, which involve a complicated and careful approach to sterilization of the cysts prior to removal to reduce the likelihood of anaphylaxis, with drugs having a less important role. Albendazole may be prescribed for long periods of time, although success is low. Importantly, regular deworming of our dogs is what protects humans and dogs from echinococcus, and effective surgical management of cysts is needed with subsequent anti-helminthic treatment. This infection can occur in Canada and the US, and so it's important to consider it in your practice. Northern Canada being a common spot for echinococcus granulosus with sheep or hunting dogs, and some places with foxes who eat voles are important for echinococcus multilocularis. Voles themselves are infected and can develop cystic disease as well. Importantly, cysticercosis in humans caused by echinococcus multilocularis can cause an alveolar cystic pattern. Remember, multilocularis and a multiloculated cyst pattern which grows outward like a cancerous lesion, causing more problems in humans than granulosis. Now for our last group, we have the Trematodes or the Flukes, which can be divided quickly by separating the Flukes by where they have a predilection for establishing residence in their human host. Flukes that infect the liver and biliary tree include Clonorchis sinensis and Fasciola hepatica. A fluke that infects the lungs characteristically is Paragonymous westermani, and the most important fluke globally, Schistosomiasis, is known to infect either the urinary bladder or the GI tract long term. The liver flukes Clonorchis sinensis and Fasciola hepatica are both flukes that are acquired from ingestion of contaminated food. Clonorchis sinensis is called the Oriental liver fluke. It is endemic in East Asia and is another helminth acquired from undercooked freshwater fish like the nematode Anisakis and the tapeworm Diphyllobothrium. Clonorchis travels into the GI tract and establishes residence in the hepatic ducts. Fasciola hepatica is also known as the sheep liver fluke and has a life cycle in sheep, but interestingly, humans are commonly infected when eating contaminated water plants like watercress, a water plant that's commonly used in salads in some places that is contaminated with sheep feces. Fasciola also travels into the intrahepatic ducts to create a home, but is more common in Europe, Africa, China, and South America. Presentation of both liver flukes is initially asymptomatic, rarely any right upper quadrant pain or jaundice. However, over time, some problems occur related to the liver. Most importantly, Clonorchis sinensis has actually been associated with the development of cholangiocarcinoma, but both flukes can contribute to a portal fibrosis and cholestatic liver injury picture, and rarely, if any, raw liver or sheep liver is actually eaten, patients can get a pharyngeal fascioliasis, commonly seen in the Middle East, which they refer to there as halzoon. Diagnosis is through stool ova parasites and serology, and treatment is specific for each worm. Praziquantel is effective for Clonorchis like it is for most flatworms, but Fasciola hepatica is the one flatworm to remember that is resistant for some reason to praziquantel and does not respond to treatment, but does respond to nitazoxanide, mebendazole, or triclobendazole. More importantly, ERCP removal of fasciola results in the best clinical outcome. Our lung fluke, Paragonymous westermani, is acquired from eating undercooked or pickled freshwater crustaceans, i.e. crabs, lobster, or crayfish, and can occur worldwide, but most commonly by custom in Japan, Korea, Taiwan, China, and the Philippines. The ingested fluke enters the GI tract, penetrates into the peritoneum, and then into the pleural space where it invades the lungs. Paragonymous can live and survive in the lungs for 20 to 25 years, where it occasionally is coughed up and spat up, swallowed again into the GI tract, and then defecated. Most patients are asymptomatic, but some develop a more chronic Loeffler syndrome type picture with hemoptysis and pulmonary eosinophilia that can kind of look like tuberculosis, as well as perhaps a nausea, vomiting, diarrhea, or urticaria related to worm migration. Chronically, migration can lead to space-occupying lesion development in the brain, liver, or spinal cord. As humans are a dead-end host, they migrate and die. Diagnosis is more reliable via stool ova parasite, but also sputum microscopy, treatment again being with praziquantel. Lastly, the most important fluke to know is Schistosoma species, of which several species cause important infection in different geographic locations throughout the globe. Schistosoma, unlike other trematodes, is acquired by burrowing through the skin, like our nematodes, strongyloides, and hookworms. Although it is not through human feces, instead it's from water, contaminated with a high population of infected snails, which are the intermediate hosts. There is a variant of schistosoma infection common in North America, known as swimmer's itch, which involves infection in water with snails, with avian schistosoma. Although this variant burrows into the skin, it dies there, causing an itchy cercarial rash. Human schistosoma is much more severe, causing burrowing into the skin and migration thereafter to either the GI tract with most species, for example, Schistosoma japonicum or mansoni, or the urinary bladder with Schistosoma hematobium. This could occur anywhere on the planet with an uncontrolled infected snail population or poor sanitation and nil sewage, since humans would reinfect water with fecal matter. It ends up being more common in travelers or immigrants from Southeast Asia or Africa and the Middle East. Importantly, it is suspected that 1 in 30 humans on the planet are infected with schistosoma, making it an incredibly important public health problem that involves targeting overpopulation of snails. Acutely, patients may notice a cercarial dermatitis related to burrowing and migration through the skin, which looks like the rash seen on the left, or less commonly something called Katayama fever, which involves a systemic delayed hypersensitivity to infection and migration, appearing like a serum sickness-like reaction with eosinophilia 2 to 4 weeks post-infection. Chronically, however, patients can have devastating consequences if they're untreated. With Schistosoma hematobium, schistosomes burrow into the bladder wall, causing a chronic cystitis with hematuria, and eventually causing a bladder squamous cell carcinoma, which is a rare bladder cancer histology if untreated. In Schistosoma mansoni and japonicum, among others, it burrows into the GI tract wall and causes a bloody diarrhea and a portal hypertension due to venous congestion, as well as an iron deficiency anemia. There have been reports of recurrent salmonella bacteremia in these patients who have increased GI tract permeability. Diagnosis and treatment is luckily simple, with stool ova parasites and serology being effective for most patients, and a short course of 1 day of praziquantel being effective, with retreatment being seldom required. Most importantly, breaking the life cycle is important to controlling this for the population at large. As you can see, Schistosoma hematobium really is more endemic to Africa and the Middle East, whereas GI tract schistosomes are diffuse across Africa, Southeast Asia, and even South America and the Caribbean. Now we've reviewed a lot of material. Let's test ourselves with a quick quiz to refresh our memory and consolidate our learning. First, which are our clinically relevant vector-borne helminths? Remember, the only ones to remember are our nematodes carried by mosquitoes, namely Wuchereria bancrofti and Brugia malayi, and the biting flies carrying Onchocercal and Loa loa. Second, which worms cause infection through burrowing through our skin and migration? Two groups do this, of course, are hookworms and strongyloides, but also schistosoma, which is unique for a trematode. Third, which worms have a lung portion of their life cycle? This would be important to know since we could narrow our search if we suspect Loeffler syndrome clinically. Of course, this involves the unsanitary tetrad worms, Ascaris, hookworms, and strongyloides, but not the whipworm, as well as Paragonymous, which is a lung fluke. You could also consider larva migrans by Balis ascaris through this syndrome, although it is distinct, or a tropical pulmonary eosinophilia of lymphatic filariasis. Fourth, which worms are acquired from eating undercooked seafood? This, of course, involves Anisakis simplex, Angiostrongylus, if you include snails or slugs, Diphyllobothrium latum, Clonorchis sinensis, and Paragonus westermani from crustaceans. Fifth question is, which worms are acquired from contact with pets or animals? Remember that this includes nematodes and one tapeworm, being Toxocaris canis or cat-eye with dogs and cats, Balis ascaris with raccoons, and Echinococcus granulosus with dogs, or Multilocularis with foxes or other wild dogs. 6. Which worms are associated with infection from undercooked bear or cougar jerky meat? This refers, of course, to trichinosis caused by Trichinella spiralis. And seventh, which worms are associated with poor sanitation and lack of sewage facilities. Remember the Tetrad, Scarus, whipworm, hookworms, and strongyloides. A few more questions. Eighth, which Helminth infections completely bypass the GI tract and therefore would not appear in a stool ova and parasite? This refers predominantly to the vector-borne Helminths. Even other worms which burrow into the skin may make their way to the GI tract like Schistosoma. Ninth, which flatworms are not treatable by praziquantel? This refers to two problems. First, in cysticercosis, which is tricky to deal with praziquantel alone, and any anti-helminthic alone and requires surgery, which obviously refers to echinococcus as well. And second, it refers to Fasciola hepatica, a worm treatable by ERCP removal or nitazoxanide, but not reliably with praziquantel. 10th question is, which helminths have realistic reservoirs in Canada and North America? Remember that pinworms exist all over the planet, and specifically Toxocara, Trichinella, Balis ascaris, and Echinococcus are the important worms to notice for endemic infection. 11th, in which helminth infections can the eyes be involved? Remember that the migratory worms Toxocara, Trichinella, Balis ascaris, and Angiostrongylus can have forms which migrate to the eye and cause periorbital swelling. Toxocara, Balis ascaris, and Loa loa can all have ocular larva migrans, whereas Onchocercovolvulus causes a more vision-threatening disease with lens subluxation and blindness. 12th, which helminthic infection and drug combination causes the Mazzottai reaction? So remember, this refers to diethylcarbamazine for Onchocercovolvulus infection, but can also maybe involve ivermectin or praziquantel. Lastly, 13th question, which helminths are endemic to Southeast Asia and may involve travel to this region? In addition to our helminths acquired via consumption of undercooked seafood, we have Angiostrongylus cantonensis from eating snails or slugs, and Schistosoma japonicum or Mekongai, which are non-bladder schistosomes. And with that, we finished part 1 of a 2-part series on helminthic infections. In the next lesson, we'll discuss some detailed anti-helminthic clinical pharmacology, do a quick quiz on these agents, then go through some clinical cases to reinforce our knowledge with helminthic infections. Lastly, we'll briefly touch on helminthic infections in veterinary medicine. Thank you for watching.